we're going to talk about anti-lipemic drugs. First, we're going to talk about how the body uses cholesterol. So we ingest triglyceride. Having trouble with this pen. Okay. It goes to our small intestine. The small intestine meets it up with a chylomicron. So you have a chylomicron. Which is kind of like transport for your triglyceride. So it grabs the triglyceride. So this thing goes all together. Okay. And it goes to the liver. So we're going to draw a liver over here. It's our liver. So our liver is going to use HMG CoA reductase. And this will make sense in a minute. I'm trying to write this and it's just not wanting to write it. Okay, it uses it. The liver uses HMG CoA reductase to make a very low density lipoprotein. Okay, so what this looks like, what this VLDL is it's, I don't know why this moved. Hold on, making marks all over the place. It's a triglyceride attached to a cholesterol. Okay, so we have that together. Okay. And it has an apolipoprotein in it. Okay. So this whole thing, this thing right here, is your VLDL lipoprotein. Okay. Now this goes out. Trying to write, it's not writing. Okay. So we're going to have, it takes its triglyceride. Now the triglyceride comes out and it can either go deposit on an arterial wall, or this triglyceride can go into the cell because the cells need triglyceride. Once it loses this triglyceride, it now becomes just cholesterol. So we have just cholesterol. With this apolipoprotein. It becomes this hold on, I messed this up. Sorry. So the VLDL is going to give up its triglyceride to either be deposited on the arterial wall or into a cell. The rest of it goes to as a intermediate density lipoprotein back to the liver to become now an LDL, which is a low density lipoprotein. Okay, so that's what this thing right here is your LDL. So when we talk about the bad cholesterol, we're talking about this. Now, VLDL is what we consider our triglyceride level. When we're talking about our triglyceride level, we're actually talking about how much VLDL do we actually have in our bloodstream. So with this, the cholesterol goes off. Let's make this a tad bit smaller. Maybe not. Let's see if we can make this. Okay, so your cholesterol, I'll have to make that back to normal size here. Goes out, and it now can either go to cells or go to the arterial walls. Okay? Now, once this LDL loses its cholesterol, it goes back to the liver, where the liver uses it either to make more cholesterol, so more LDL, or make more VLDL, or it about 50% of it uses it to make bile. And you need bile. Bile goes into the small intestine. Where it is used to digest fats. And then it goes out as stool. So it's excreted in stool. So when we talk about having cholesterol in our system, trying to put this back on, okay, we're talking about our VLDL, which is going to be our triglyceride level, and we're talking about LDL, which is our low density lipoprotein. It's our bad cholesterol. Now what happens later on with this is that the liver actually also makes HDL. HDL is a good cholesterol that actually comes along and it cleans up any extra triglycerides or any extra cholesterol that's hanging out in the system. Okay? So it's kind of like our cleaner, and it brings it back to the liver to reuse it, kind of like to recycle. Okay, so it'll bring back any LDL, it'll bring back any triglycerides, anything that's hanging out that's just not doing anything. It'll bring it back to the liver for recycling. Okay? All right, so our overview of cholesterol. So the liver regulates cholesterol. You can see how the liver is responsible for making much of the cholesterol, or actually all of it, once it comes in from the small intestine. Okay, comes in from the small intestine, goes right to the liver to be made into cholesterol, different types of cholesterol. The liver uses CoA reductase in order to make the cholesterol. Okay. It also is going to remove cholesterol, as we see, once it loses that VLDL, lost its right here, when the VLDL loses its triglyceride, that IDL, the intermediate density lipoprotein, goes back to the liver, okay? And then once the LDL comes out and it loses its cholesterol, it goes back to the liver. So the liver removes cholesterol also from the bloodstream. It is a negative feedback system. So the higher your cholesterol is, the less that your liver is actually going to make it, right? If you have a ton of it already in the system, then the liver doesn't need to make any. So it will decrease the amount that it makes, and it will also decrease the amount of receptors, which is the least amount of cholesterol it takes in means it'll decrease the amount of cholesterol that it actually produces. So the lipoproteins, the VLDL and the LDL, that's how cholesterol actually circulates. It's like it catches a ride. The triglyceride and the cholesterol hitch a ride on the lipoprotein. It's kind of like their transportation. And we showed that the lipoproteins contain triglyceride, cholesterol, and an apolipoprotein. And the VLDL contains all of them. The LDL only contains the cholesterol and the apolipoprotein. So we have 4 types of lipoproteins. You have the chylomicron and the VLDL. Again, the chylomicron, it carries the triglyceride to the liver. It's synthesized by the small intestine to transport the triglycerides absorbed by the small intestine to the liver. The VLDL is then synthesized by the liver using that triglyceride. Okay. Again, we use the VLDL level to determine what our triglyceride level is, because that's the only way that we can do it right now. So the chylomicron and the VLDL delivers the triglycerides to the body. And they can either go to the arterial walls and build up, causing atherosclerosis, or it can go to the cells. Then it goes back to the liver to be made into LDL. LDL, again, synthesized by the liver, which with the help of that HMG coenzyme A, right? And it delivers cholesterol to the body, which is either going to go, again, to the arterial walls, or it's going to go to the cells. HDL is synthesized by the liver and small intestine, and it cleans up. So it moves around circulations, cleaning up the LDLs and any other unused lipids to take it back to the liver to kind of be recycled to be made into more cholesterol and triglycerides. So cholesterol and coronary artery disease. If you have increase in cholesterol, it increases your incidence of death and disability related to coronary artery disease, okay? So 50% of all Americans will die from a myocardial infarction, which is brought about by coronary artery disease, okay? If you have coronary artery disease, you're clogging up your vessels, and if you clog them up enough, you stop circulation from getting to your heart muscles, and you have a heart attack, which is a myocardial infarction. So the best way to prevent a myocardial infarction is to decrease our cholesterol levels, right? Because if we don't have high cholesterol levels and it can't build up, it can't occlude the circulation, thus you won't have a myocardial infarction. So there are risk factors associated with development of cardiovascular disease, and basically they're summed up in metabolic syndrome, okay? So all of these things are going to be a risk factor for development of cardiovascular disease. It's like the trifecta. If you have obesity, you have hypertriglyceridemia, okay, which again we measure using the VLDL, and low HDL, because HDL is what gets our bad cholesterol out of our system, brings it back to the liver to be recycled. Okay, so hypercholesterolemia, lifestyle modifications that they would like for you to do: decrease saturated fat, high fiber diet, increase in vegetables, weight loss, and increase in activity. they say that even a small weight loss can improve lipid levels and decrease our risk for heart disease. So it's super important. In your book on page 439, they actually have some guidelines for patients who should be on cholesterol medication, statins, which we'll talk about in a second. A patient with coronary artery disease on lipid-lowering meds have shown a decrease on coronary events, regression of atherosclerotic lesions, so it's actually taking away that buildup that we're seeing on the vascular space, and prolonged survival. Also, an increase in consumption of fatty fish, like omega-3 fatty acids, have shown to decrease triglycerides and increase HDL levels, which I can attest that actually works because I have really high cholesterol and I did not want to go on a statin, like really high as in 270s. And so the only other option was to go on a fish oil supplement, and I have been on one, and my HDL levels are super high. They're like twice what they should be, which is good. You want really high levels of HDL because, again, it is what's taking out that bad cholesterol. So you want those. Okay, so drugs that we use HMG-CoA reductase inhibitors, because if we're inhibiting the things that help the liver to make cholesterol, bad cholesterol, then we're going to lower our cholesterol level, right? And those are our statins. We have bile acid sequestrants, which we'll talk about, the vitamin B3, which is niacin, and then cholesterol absorption inhibitors, which we're going to talk about all of these in just a second. Okay, so the first one we're going to talk about is our statins. They are the most potent drugs available for reducing LDL levels, okay? The mechanism of action. So they inhibit the liver's production of LDL and VLDL cholesterol, okay, which is really good, okay? We saw on the drawing where liver needs that enzyme in order to make the LDL and VLDL. Well, if we make it not available, if we inhibit the action of it, the enzyme, then it will produce less of the bad cholesterol, okay? If we have less, if the liver's producing less and putting out less in circulation, it decreases the amount of LDL levels that we're going to have. Thus, the liver's actually going to also decrease the receptors going to increase the amount of receptors that are on the liver because it's going to be sucking it in because it needs some recycling. It needs some help to produce more cholesterol. Okay, so that's going to also lower our LDL levels. So with patient teaching, something we have to think about is it may take 6 to 8 weeks for the maximum LDL to decrease. So we need to tell our patients this, that it may take a little bit of while, to see a difference in our labs. But it is definitely considered the first line of therapy for hypercholesterolemia. The lipid-lowering activity is dose-dependent, so the more drug you're given, the more it drops your LDL levels. So depending on how high it is, they may start high or they may start low. It just depends, and then go from there. So your adverse effects are hepatotoxicity. It's really bad on the liver because we're manipulating the liver, right? The liver's trying to work, but it doesn't have the enzyme it needs in order to work. So it puts some stress on the liver. So as a nurse, we're going to be monitoring our liver function test, our AST, ALT, frequently, right? And we'll talk about that in a minute, how often. So with patient teaching, we want them to report any signs and symptoms of hepatotoxicity. So what are those signs and symptoms? That would be nausea and vomiting, anorexia, or jaundice, okay? So they need to report any kind of those signs and symptoms to let us know that it may be too harsh on their liver. So myopathy is a big one with statins, and myopathy means muscle pain, okay? So they first develop muscle pain. This muscle pain can then develop into rhabdomyolysis, which is actually a breakdown of the muscle. This breakdown of the muscle means that you have myoglobin floating around in the bloodstream, a high concentration, which then goes to the kidneys. You get myoglobinuria. Myoglobin is a really big molecule, so it clogs up the kidneys. It blocks those holes, okay, so it can't filter, and it blocks the renal tubules. So you get acute renal failure. That acute renal failure can then turn into death, okay, can kill you, okay. So we definitely want them, any kinds of signs and symptoms of myopathy, they start getting muscle pain, they start having dark urine, muscle soreness. That would be part of our patient teaching. You know, please report any of these signs and symptoms because it definitely could be something serious. As a nurse, we're going to be monitoring their CK levels, their creatinine kinase levels, which is something that is produced when you're breaking down muscle. Okay, so it would tell us that yes, this patient is breaking down their muscle. We would need to stop the statin, and it's actually a reversible state. If you stop the statin, it will go back to normal. So definitely something though our patients need to know about and need to report if they see any signs and symptoms of that. So again, with patient teaching, we need to tell them that they need to take it at night because this is when your body normally makes its cholesterol anyway. So this is the high production time. So we want to affect it when it's being most productive, right? Contraindications would be liver dysfunction. That makes sense because we are manipulating the liver. If the liver's already having a hard time, we don't want to give it a medication that's going to further complicate things. So if they have any kind of liver dysfunction, we don't want to put them on a statin. Interactions, anybody taking anticoagulants, because the liver is very involved in the coagulation process, okay? The liver actually makes the factors, okay? And so if the liver is compromised, it may not make those factors like it should, and your body won't coagulate like it should. So that could potentially delay the coagulation process anyway. So if patient is on an anticoagulant, this could further complicate things. So we may need to monitor their PT levels a little bit more closely if they are on anticoagulants. Meds are foods that may decrease the metabolism of statins. If they're decreasing the metabolism of statins, then that means that they're increasing the concentration of statins because they're staying around longer, okay? If they're staying around longer, then that's going to increase your risk of rhabdomyolysis because the higher concentration of statin, the higher your risk of rhabdomyolysis. There are some antibiotics, some antifungals that cause it, will increase concentrations, fibrates, and grapefruit juice, interestingly enough. Although your book says less than 1 quart per day. So unless you're drinking a whole heck a lot of grapefruit juice, it shouldn't really affect it. But if they're drinking a lot, then maybe we need to decrease the dose of the statin, okay? So further patient teaching, they need to have labs drawn every 6 to 8 weeks for the first 6 months because we're trying to figure out what's a good dose for them. We don't want too much, because if you have higher concentrations of statin, you increase your risk of the myopathies and the rhabdomyolysis. So you want the lowest dose that will do the job. Okay, so we're gonna monitor it really closely, kind of, increase or decrease the dose in that first 6 months. Then hopefully within that first 6 months, we're all good. We figured out a good dose. And then we're going to monitor every 3 to 6 months, monitoring our cholesterol levels. We're going to be monitoring our liver enzymes because we want to make sure that we're not doing damage to our liver. We're not causing that hepatotoxicity. They need to take the meds with 6 to 8 ounces of fluid just to decrease any GI upset if they have some, which they may or may not have. And of course, we need to teach them to avoid any drug or food interactions. And report any new symptoms because we want to know, are we having signs of hepatotoxicity? Are we having signs of myopathies or rhabdomyolysis? Okay, so we need to educate them on what those signs are. Our next category is the bile acid sequestrants. So think of sequester means to remove or isolate, and that's exactly what it does to the bile. So this is your second line drug after statins. It's commonly used with statins. So the mechanism of action is it kind of prevents the bile acids from being absorbed into the small intestines. So the bile acids are just hanging out in the small intestines. The only problem with that is they tend to clump up a bit. So the adverse effect is that it causes constipation. So you need to make sure your patients know, hey, you may want to drink lots of water, take some fiber supplements, maybe do some exercise to help peristalsis keep on going, because those bile acids can absolutely clump up and cause some problems. So why does that help? Why does it help for us to not use bile acid? Well, we need bile acids in the small intestine in order to absorb fats. So if we don't have bile acids, the small intestine is going to tell the liver, hey, liver, I need some more bile acid because you're not giving me any. So the liver has to take cholesterol from the blood to make more bile acid. So if the liver has to take more cholesterol from the blood, that decreases our cholesterol level in the blood. Okay? So contraindications would be any kind of biliary or bowel obstruction because they're already at risk for obstruction, right? So if they already have narrowing of the bowels or anything like that, we probably don't want to give them this because this would further complicate any kind of problems they have with peristalsis or anything like that. So interactions, it can affect the absorption of other drugs because it affects the absorption of bile acids. It can tend to also affect the absorption of other drugs. So we want to give other meds are going to be taken at least 1 hour before or 4 to 6 hours after a bile acid sequestrant. So they really need to time their medications well. They may have malabsorption of your fat-soluble vitamins because, again, we needed that bile for the small intestine to be able to absorb and break down fats. Well, if it can't do that, then it won't have the fat, which is available to take in our fat-soluble vitamins. So they may get depleted of their fat-soluble vitamins. So we just need to make sure, and those are A, D, E, and K. So we would need to check labs to see if they're doing okay with that. Also, a good way to see that is if they have fatty stools. They have fatty stools, they're not absorbing any fat, and that would definitely indicate that they're probably going to be deficient in the fat-soluble vitamins. So patient teaching, definitely other meds have to be taken at least an hour before or 4 to 6 hours after this med. If it is in a powder form, they have a pill form, but they also have a powder form, which is much more common. You have to dissolve it with 8 ounces of fluid really good, like a whole minute. They say to mix it for a whole minute before taking it because they say it's a choking hazard if you don't mix it up really well. So make sure you do that. And you take it right before you eat. Okay? Now, it does contain aspartame. Why is that important? Well, aspartame contains phenylalanine. So that means that patients who have PKU, phenylketonuria, which is a birth defect that causes phenylalanine to build up in your body. So if you have PKU, you don't want to take this medication because it will build up phenylalanine. So just one of those things to note that it has it in there. So now we're going to talk about niacin. Niacin is actually vitamin B3, but it's in much larger doses than you normally would be taking. It's not recommended as a first-line therapy, but sometimes it's given in combo with something else if that's, not really cutting it by itself. It lowers triglycerides and LDLs and increases your HDL level. So basically it reduces the breakdown and use of cholesterol and triglycerides. So our adverse effects The biggest ones are the flushing and GI distress. This is basically caused by a histamine release. So the patients need to know that if they get this flushing sensation, which it happens pretty often, they can take aspirin 30 minutes prior to the dose, and that will actually decrease the flushing, the histamine release. It also can cause hepatotoxicity. So as a nurse, we need to look for signs and symptoms. We need to educate them about signs and symptoms of hepatotoxicity. We need to monitor their LFTs, right? We need to, hyperglycemia is a potential. So as a nurse, we need to be monitoring their glucose levels, even if they're not diabetic. Now, patients that are diabetic, they need to be monitoring more closely their glucose levels and actually watching for signs of hyperglycemia. It can also cause hyperuricemia, so high uric acid levels. So as a nurse, we are going to be checking their uric acid levels. We're going to be monitoring our patients for any kind of joint pain, especially big toe joint pain. It's a sudden severe swelling. Feels like their big toe is on fire. And we would educate our patients on what the signs and symptoms of gout are so that they would know what to look for and to report those. So the effects of niacin are noticed around 1 to 4 days after therapy. It does not have any effect on cardiovascular outcomes. Like statins, they have really good cardiovascular outcomes. Like because of the decrease in the LDLs, we're seeing a decrease in the incidence of cardiovascular incidents. We don't necessarily see that with niacin. That's why it's usually an adjuvant. It's like a bonus kind of med to kind of help a little bit. Definitely not given by itself. So contraindications, liver disease. It can potentially cause hepatotoxicity. So if you already have some kind of liver disease, you're not going to want to be on this. If you already have gout, it can cause gout. So if you already have high uric acid levels, you don't want to be on this. You want to use caution with peptic ulcer disease and diabetes. That is because it does cause an increase in our GI motility and acid secretion. So it can make your peptic ulcers worse. And with the diabetes, it can cause hyperglycemia. So we just want to be monitoring more closely our blood sugars. So interactions, it can increase the risk of myopathy when taken with statins. A lot of these drugs, when taken with statins, are going to increase the chance of myopathies. So just as a note, so patient teaching, report any new symptoms. So any symptoms of hepatotoxicity, symptoms of hyperglycemia, GI symptoms, the gout symptoms, okay? Make sure they know that they can take the aspirin 30 minutes prior to dose to help with that flushing. Take with meals, that'll help with the GI effects. And then they're going to have labs drawn to monitor these potential adverse effects. Okay, our fibrates, they primarily decrease triglyceride levels, which is our VLDL, and increase our HDL. They can induce an increase in breakdown of clots, so that can cause a problem. Mechanisms of action, it reduces the liver's production of VLDL and speeds up the removal of triglycerides from the blood. Other classes are generally used first. So our adverse effects are GI distress. Usually it's mild and goes away over time. It can cause gallstones as well. So as a nurse, we're going to monitor for right upper quadrant pain. We're going to teach our patients to notice if they have any issues with digesting fats. Usually they'll have abdominal pain or bloating after eating high-fat foods. It can cause myopathy. So as a nurse, we're going to check CK levels. We're going to monitor for any muscle aches and pains. We're going to educate our patients about reporting any muscle aches and pains. Hepatotoxicity. As a nurse, we're going to monitor our liver function test, which is our AST and our ALT. As we're educating our patients, we're going to talk to them about the signs and symptoms of hepatotoxicity, which are jaundice, nausea, vomiting, and anorexia, which y'all are going to know really well by the end of this lecture. So contraindications, severe liver disease or kidney disease, and gallbladder disease, because the adverse effects involve those organs, okay? Interactions, anticoagulants, we talked about that it increases the breakdown of clots. So we need to, as nurses, maybe monitor for signs and symptoms of bleeding, okay? Increased bleeding. We may monitor our PT times, and we would educate the patient on reporting any signs and symptoms of increased bleeding or bruising, bleeding when they brush their teeth, stuff like that. So statins, if they're used with statins, they're going to increase the risk of myopathy and rhabdomyolysis, which, we already said that much of these things, when they're used with statins, they're going to increase that risk with statins. So patient teaching, remember, report those new symptoms, any new symptoms, and then take 30 minutes prior to breakfast and dinner is when they should be taking it. So cholesterol absorption inhibitor, there's only one, okay? The mechanism of action, so it inhibits the absorption of cholesterol in the small intestine, which results in a lowering of the LDL. Adverse effects, it can cause hepatitis, which is different than hepatotoxicity, okay? So we're going to monitor, as a nurse, we're going to monitor our liver function test. We're going to teach our patients about signs and symptoms of hepatitis, and that they need to avoid alcohol is super important. Another adverse effect is myopathy. So as nurses, we're going to monitor for muscle soreness, and we are going to check CK levels if they report any muscle soreness. We're going to teach our patients the signs and symptoms of myopathy and to report any signs and symptoms that they see. Interactions, fibrates, and then caution with other anti-lipemic drugs. So patient teaching basically is report new symptoms, okay? So if they notice anything new, especially that could be liver related or muscle related, they need to go ahead and report that to the prescriber. So as assessment, as a nurse, what are we going to assess? Well, we want to ask them if they're on any herbals, any supplements, what is their food intake, dietary pattern, do they do exercise, do they drink gallons of grapefruit juice, because that might be a problem. Patient family history, do they have PKU in their family, okay? Do they have any positive risk factors for coronary artery disease? Those would be like increased age, if they're male, if they smoke, increased blood pressure, increased cholesterol, obesity, and diabetes. All of those are risk factors for coronary artery disease. Do they have any musculoskeletal problems? We need to know baseline. Do they have any issues to begin with before we start them on medications that may cause muscle problems? Do they have any contraindications? Do they have any liver issues, kidney issues, gallbladder issues, bowel issues, okay? With implementation, we need to monitor for absorption issues like ADEK. If they have any, we may need to give them supplements. We want to monitor for any new symptoms, so we're going to be checking their, reviewing their labs, okay? We will do their labs as a baseline before they start the medication, and then they're going to see a trend every few months to see, okay, are the liver enzymes increasing? Is there a problem? Is the uric acid levels increasing? See if there are any adverse effects that we need to do something about. And then evaluate. How do we evaluate? Did the treatment work? What are our cholesterol levels now? Was this effective for our patient? So lastly, with patient-centered teaching, mostly it's going to be reporting new or troublesome symptoms. Troublesome because if they really annoy the patient is not going to take the medication, okay? So even if it's something totally benign to us, if it's enough of an aggravator to the patient that they don't take it, we need to change the medication, okay? They need to do a journal with their intake and their diet. It helps to monitor for ways of improvement maybe, or just maybe there's a better option of medication. Increase fluids for constipation and fiber. You can't just do fiber, you need to do fiber plus water, okay? They need to remember to still continue non-pharmacological interventions. That'd be like their nutrition and diet, exercising, stress reduction and relaxation. We could all use that, right? To further help the cholesterol levels to decrease. Because maybe if they do enough, they could get off of their cholesterol meds.